Hello, good evening, everyone, and thanks for waiting. We had to combat some network issues as usual, and Kolkata team is with us now. Let me welcome Professor Dr. D.P. Bakshi, sir. Pranam. How are you? And Debadyuti and Professor Dr. A.K. Pal. Hi, how are you? Um, as I'm going to share my screen, so if someone can unshare here and let me share my screen. Or someone wants to introduce, go ahead quickly.
Yes, I am Vidhan Patnaik. Good evening to all doctors. Let me introduce Dr. Sushant Wabulkar. He is a founder member, International OTA, President, Trauma Society of India, Vice President, NAILS, Member Task Force, Lower Limb AO Trauma, Regional Chief, Center for Joint Reconstruction Surgery, Sushruth Institute of Medical Sciences. Uh, Let me introduce Dr. D.P. Bakshi. He is the Director and Consultant Orthopedic Surgeon, Bakshi Orthopedics Trauma and Rehabilitation Center Private Limited. Described the pesplasty for different patellar dislocation. Designer of total elbow prosthetic replacement. Popularized that basic technique of muscle pedicle bone grafting for osteonecrosis of femoral head, ununited femoral neck fractures, and spondylolisthesis. Professor Dr. D.D. Bakshi, Director and Consultant Orthopedic Surgeon, Bakshi Orthopedics Trauma and Rehabilitation Center Private Limited, Expert Organizer and Superb Surgeon of Super Specialty of Orthopedic Hospital, proponents of works of Professor D.P. Bakshi, modified the surgical techniques of pesplasty, total elbow replacement, and muscle pedicle bone grafting. Professor Dr. A.K. Pal, Consultant Orthopedic Surgeon, Bakshi Orthopedics Trauma and Rehabilitation Center Private Limited, youngest Professor of Orthopedics Expert in Minimally Invasive Surgery. Proponents of works of Professor Bakshi modified the surgical techniques of pesplasty, total elbow replacement, and muscle pedicle bone grafting. Welcome to all of you. Dr. Sushant Wabulkar, sir, over to you.
Yeah, thank you very much, Vidhan. Appreciate that, and I at outset would want to thank Science Integra and Juventus to put this together. So the whole idea today is to discuss about osteonecrosis, and Sir Professor Bakshi is the one who has created this surgery wherein we salvage or save the hip. So let's look at this. What happened in COVID-19 was there were lots of systems which were affected, musculoskeletal also amongst one of them, and osteonecrosis forms a very integral part of it, and we all know and we have published a lot on that subject. And in our part of the world, in Nagpur, around Nagpur in central India, we get a lot of sickle cell patients. So today's thought process is to see where we are today and to think how we can diagnose these patients of avascular necrosis early on and offer them various treatment options. So, of course, with crescent sign, we know that we have already reached stage 3. Patient will present to us with any amount of pain, but it can be localized to mainly hip joint, but it can radiate to medial aspect of thigh. It can be lumbosacral pain, also radiating to the knee. But this sectoral deviation test is positive and it directs us towards hip joint. So of course, in diagnosis, we can start from X-rays, but MRI is the standard. And we all know about classification. I will not go into the details of that. ARCO tends to be the standard classification all over the world, wherein stage 1 is the early stage and stage 4 is the last stage of arthritis. So to mention, bone scan also has its role. We don't do bone scan anymore MRI has replaced all the investigations. And in T1 and T2 weighted images, what we look for is band-like images, and that's a double line sign. And MRI has high specificity, high sensitivity, and of course, then we come to management, which depends on age of the patient, whether we are looking at unilateral or bilateral, and also what is the etiology of the disease. Today, we will restrict our talk to steroid-induced, and we will talk more of biological approach, for which Professor Bakshi entire team is here, and we would want to discuss about his technique which he has designed, and we would want to hear from you, sir, more about muscle pedicle bone grafting. Sir, over to you. How do you choose the patient of muscle pedicle bone grafting? On his behalf, if Debaduti, you want to speak, or Dr. Pal, you want to speak,
Yeah.
we are open to ideas, and either one of you can speak, and I will fire questions to extract more answers from you.
Yes, thank you, sir. The indication for the muscle pedicle bone grafting, what we are propagating is the tensor fascia lata bone grafting, where we do a subarrector tenotomy followed by a chilectomy muscle pedicle grafting. Is that ideally the patient should be in stage 1, stage 2, but we also have a series of Ficatale stage 1, stage 2. And
Okay, can I stop you there, Debaduti?
Yes, sir.
I'm going to take one by one so that audience get more knowledge from your group.
Okay.
So stage 1,
Yes.
which is a stage wherein only MRI is positive, X-ray is almost normal, patient presents to us with pain. There is also a study of non-surgical management using bisphosphonates.
Yes.
Do you at all do that, or you do not do that?
No, we do not do, sir, bisphosphonate because we give it, but actually we always propagate to go for a surgical management, in the sense that there is a very high chance that the stage progression in AVN is very fast, and that can lead to compromise of the surgical result if the head progresses to a higher stage.
I got your point. So there are some patients on day 1, you can identify that, okay, this patient of stage 1 is going to climb up to stage 2 very early. Can you tell us some tips and tricks to identify those stage 1 patients in whom you should immediately advocate surgery, and those patients in whom you can probably advocate conservative management, like maybe bisphosphonate, or maybe just core decompression, which is a kind of a conservative surgery?
Yes, sir. The bisphosphonates actually has been propagated by Dr. Sanjay Agarwal of Mumbai.
Yes.
And he has shown good results that even by applying bisphosphonates, there is chance of reversible of the condition.
Yes.
But actually, most of the patients who present will have that pain around the hip, which is actually affecting their activities of daily living. And in this situation, it has been seen that within 3 months, also it has been advocated in Campbell that there is a very high chance of getting into worse radiological position in a period of 3 months. And core decompression alone, we don't, because core decompression alone will help in release of the venous stasis which occurs in the subchondral area. But unless we give something which will increase the blood supply, because osteonecrosis, it is the death of the bone due to the lack of the blood supply. So muscle pedicle bone grafting actually helps in revascularization of the bone and improving the because the actually in osteonecrosis it's like a boiled potato. The bone becomes very soft, and hence it is always better to give a definitive surgical intervention in the first stage only, and add bisphosphonates to it. That will always be helpful.
No.
Pal, you wanted to
Yes.
say something?
Yes, yes. So first of all, your question was how to identify the grade 1, stage 1 osteonecrosis. That is one. Second question here is how to choose the patient under the scalpel. So that is the second question. So yes, it's a very valid question. In osteonecrosis, its pain starts very early, and there's a pain character, especially it is the anterior anteromedial, as you nicely described, especially at rest. That is the pain at osteonecrosis occurs usually at the rest. So rest pain is the hallmark of osteonecrosis, and usually patient comes with this complaint that when the patient lies in the bed and patient is complaining of pain even in the middle of the night, just like the inflammatory pain, like as is occurred in the early part of the body. And once the patient is investigated, they examined, there's a range of motion is almost completely full, except there are some terminal limitation of internal rotation. That is the first clinical sign. Actually, in my practice, I have noticed there is a terminal restriction of internal rotation. It is the first sign, along with the complaint of rest pain. So in clinically, and if the radiological is absolutely normal, if you do the MRI at this stage, then you can only diagnose that is diagnosis is a double line sign. But again, for the audience, I just discussed this another study, that is a Mitchell et al. They have done an elaborate study of this sort of type 1 patients. They have used that the osteonecrotic area in T1 weighted image and the T2 weighted image, and they have elaborately examined the character of the osteonecrotic center, lesion of the center. There are 3 types of character: either the dark character, it may be bright character, or it may be indeterminate, that is in between the two, that is indeterminate character. So if it is a dark, if it is a T1, it is dark. T2 is dark. This is the worst prognosis, and that actually is corroborated histologically by there are several workers, especially the Mitchell et al. They are proponent of this classification. That is the type 4, that indicates this lesion is composed of fibrotic tissue. On the other side, if it is T1, it is indeterminate, and T2 it is a bright, that indicates it is a fat. It is a fat character. It is normal. But if it is both the T1 and T2 is bright, that means it contains a blood. And lastly, it is just opposite. That is type 1, it is indeterminate variety, and type 2, it is a dark variety, that indicates it is a edema variety. So if it contains the blood, or it may contain the fat, or it contains the edema, that indicates a very good prognosis. But if this stage 1 lesion comes with a dark lesion, as per Mitchell, that is a very bad prognosis. And actually, I select those cases immediately after the scalpel. So I actually told that these cases, as it is complaining of consisting of this osteonecrotic area is consisting of fibrous tissue, they are the rapidly progresses to there is collapse in this stage 2, stage 3, even the degenerative stages. As you can already, there is a classification, the broad classification. The osteonecrosis is a pre-degenerative and post-degenerative. Pre-degenerative is a pre-collapse, post-collapse. So that is an easy classification. Actually, it is actually means follow this as per there are different ARCO. There are some FICATALET, everything. So this Mitchell classification is extremely useful guideline to select the patient, whether the patient is selected for operation or not. This is in early stage. Okay, I'm very clear now.
Yeah.
So how will you identify these stage 1 cases, and how will you identify the cases suitable for operation?
You elaborated excellently. Now my next question to you is, based on this dark and dark light configuration, can you also pinpoint to the etiology? Because if you remember the FICATALET classification when it came, and then of course rest of the classifications followed, then they also discussed about ischemic toxopathy, which was purely steroid induced vascular necrosis.
Absolutely right, sir. Absolutely.
Yeah, and those patients, if you see the X-ray, there is huge amount of sclerosis there. So not sclerosis and cystic pattern, but pure sclerosis pattern. Those are the patients who probably do not withhold collapse. They collapse very fast.
Yeah.
So probably it is dangerous to wait for those ischemic coxopathy, we used to call them, or steroid-induced avians, to wait for bisphosphonates to do the magic and wait for conservative treatment to do the magic. It is probably okay to give them early on biology or supplement femoral head with more active biology like muscle pedicle bone grafting. So what do you say about this? Can you also pinpoint to the etiology based on your MRI?
See, there is no literature support from the under this, but as you have already mentioned, that it is yes, pathologically you are right. So if you see there is significant that sclerosis, that indicates it is already late cases. And the late cases, then there is nothing to become happened, and this is a very bad prognosis. But if we get the patient in this relatively the osteolytic lytic stage, that indicates that there is a chance of this healing also, and that in that case there is a high chance of recovery and the prognosis is relatively good. So that is the prognostically, these are the usually this sort of idea we usually use for the prognostication, but there is no literature support, I can say.
Okay.
But,
My next question is to Professor Bakshi, because I remember he demonstrating surgery to me and I witnessed couple of surgeries with him, and they were the patients wherein abduction was restricted and he did the chirectomy first of the outer lip of superior lip of acetabulum, which encouraged the femoral head, and of course we made a window to push in the muscle pedicle graft also, which also did the work of core decompression. But there are some patients, sir, who come in stage 2 or stage 3 with huge restriction of movement, no chillus, so no restriction of abduction, but of course antero-superior-lateral portion is involved, so that restriction of internal rotation is there. So what should we do in addition to tenotomy to encourage the range of motion in the hip? Is there any tip or trick which you follow, sir, to encourage the range of motion? Because we want to give a better range of motion to these patients.
No.
okay, go on.
Actually, range of motions due to two things, either pain due to osteonecrosis, and
Yes.
also deformities of the femoral head or the cerebellum. Question is here, patient is in complaints of pain, only pain, treat the pain by decompressor alone, decompressor and muscle membrane grafting, because if we proved osteonecrosis, you know that osteonecrosis virtually itself get revascularized unless you stimulate them with vascularized bone graft. So you decompress it, and muscle membrane bone grafting is the best answer.
Yes.
I'm telling what sir is trying to tell. So
Yeah.
there are several sources of pain from the osteonecrosis. First of all, there is a pain is due to basically there is inside pain is coming from the inside medullary canal into intracystic pressure. There is acidic nature in the osteonecrotic area, which is the basis of this night cry. That is basically the pain at the wrist. That is one. Second, once that the collapse has become started, that that area it becomes irregular and there is a mechanical inflammation develops, and that mechanical inflammation is another cause of pain from the osteonecrosis. Lastly, if there is some significant mechanical inflammation persists for long period, there is some capsular adhesion. That capsular adhesion is also causing of pain at that area. And another, lastly, you have, as you have mentioned, there is a chillus formation. So chillus formation usually develops this anterosuperior aspects predominantly, but if it's also seen, it is on the posterior aspect, also the inferior aspect. And that in posterior inferior chillus, basically they're contributing to the rotational restriction. So what we have done, so what are the the action should be given to increase the movement, and that simultaneously that reduces the pain. So for initially we can cut the subcutaneous arrector tenotomy to increase the abduction. That is one. Second, capsulectomy. So part of the capsule actually we remove, because it is, once we try to, especially in the stage 3, once we try to open the capsule, it is seen it is significantly fibrotic. Once we cut it, there is a sudden release of pressure, and there is some joint fluid is coming out like a in a jet manner. So in that case, so we have to cut the capsule, the part of the capsule, especially the anterior aspect, so that it is adequately released. Nextly, if there is adequate synovium, that is also has to be removed adequately. And lastly, the chilus. The chilus should be cut not only from the anterolateral medial superior, and also sometimes in the inferior aspect also, to increase the range of motion, I think.
Okay. My next question to Debaduti is, Debaduti, you rightly suggested, and I agree that stage 2 should be attacked very aggressively, and muscle pedicle is the way to go. Stage 1, the world is divided into 2. Let's say you have a patient of stage 3 on one side and stage 0 on the other side, wherein MRI is positive, patient's hip is asymptomatic. So what would you do for that hip? So hip is clinically asymptomatic. You are operating the other side for stage 3.
Yes.
What would you do on the other side?
Another question I can
conservatively, or would you? What would you do?
Yes, I can modify your questions. I can modify your questions also. So that is there are some dissimilar stages. So what should be your the plan of action? Which side should be attacked first?
Correct.
That is another.
Yeah. See, stage 3, it has to be operated. The world is again divided whether we should do a head preserving surgery or we should be going for a joint replacement surgery.
No, stage 3 we agree. It has to be preserved. There is no doubt.
Yeah, we have to only think.
Tell me about the other hip.
Stage 0, if it is symptomatic, now we have to counsel the patient that we can give you bisphosphonates. You have to restrict your activities of daily living. If it gets revascularized, you are fine, but the very high chance that it can progress to a higher degree of radiological deterioration, and then you would need a head preserving surgery. So if you
would you in that hip consider a benign surgery like just core decompression?
No, if I have to go, I will do both of them together. I'll not do only core decompression. I will obviously add a muscle pedicle graft, because once we do a core decompression, we create tunnels in the femoral head. And once we put the graft, what happens is there is a permeation of the granulation tissue into the graft, and that helps in which will additional help in the revascularization. So only releasing the venous stasis, there is no harm if we add a second procedure which will take extra 10 to 15 minutes.
Yes.
Actually, I want to take that question, because see, if there are some dissimilar stages, my protocol should be always start with the lower stage first, and always I advise the patients to do both the surgery at least within 7 days interval. But if you do the relatively interval is much more, so always I do the first stage first, the lower stage first, and within 3 to 4 weeks maximally we can do the second stage, the advanced stage. Why it is?
Patient is asymptomatic.
Yeah, asymptomatic. Still, if it is asymptomatic, as this is a double set, that is the dissimilar stage, this already it is advanced, and that is asymptomatic. Lower stage is bound to be advanced. Is bound to be progress within few weeks, even with few weeks or few months. So if we don't do the surgery at early as possible, that will go in the next stage, and prognosis will be extremely bad. So always I start with the lower stage first, preferably within 7 days in the second stage. That is my protocol.
I want to listen from Professor Bakshi now. What is his take, the life message on core decompression, bone grafting versus muscle pedicle bone grafting at stage 3 and at stage 2?
Core decompression means you have created one empty space.
Yes.
Femoral head.
And of course, we put a fibula graft. I'm not going to leave it empty.
Oh, you have put a fibular graft, you know that from the nature of the fibular graft, only fibular graft is a virtually dead piece of bone.
Yes.
Necrotic area, you're giving another necrotic bone to replace it is not a ideal, good scientific idea. You must fill up with the vascularized bone, so that it vascularizes as well as decompresses, and that's
Okay.
So I want to add one thing.
Sure.
Is as you told, co-decompression with either we can use a free fibula graft, or we can use a vascularized fibula graft, or we can use a vascularized TFL
Yeah,
graft.
Chris.
Now the problem is, as Professor Bakshi told, that a dead bone replacing a dead bone will not make such a meaningful thing. Now a vascular fibula graft is a good option, but problem is it's technically very demanding.
Yes.
And second, it is on a single arteriovenous pedicle. So during the surgery, there is a high risk that there is for a torsion or injury can actually damage that arteriovenous pedicle. But in case of a tensio-fascial muscle pedicle bone grafting, there are multiple communication on the vascular in the muscle bed. So the chances of it getting injured is much less. And also in a muscle pedicle bone grafting in a TFL, that it is technically much easier. So if you compare the results and the technical issues, the TFL muscle pedicle grafting is superior. Even in the 15 years results, it has been shown in Integra's CCOT that the TFL has a better result than vascular fibula grafting, along with co-decompression.
Yeah.
Yes. Just I want to add some.
Sure.
There is a non-vascularized fibular graft. It has a Dr. Chacha et al. He has made a histopathological study with this non-vascularized fibular graft. He has seen that non-vascularized fibular graft, when it is used in a bed, it remains acellular for 13 weeks. From 13 weeks, it remains acellular. From 13 weeks onwards, it getting to become revascularized, that with the help of the creeping substitution, as it is a non-vascularized. So 13 weeks time it requires to become revascularized. So if we use this on in a relatively avascular bed, so that is the problem, as Dr. Bakshi is rightly mentioned. Another Indian study is Dr. Nagy, this O.N. Nagy. He has made a beautiful study in his center. He has used this non-vascularized graft in neck femur fracture, intracapsular neck femur fracture, and he made a comment. It is a historical comment that it becomes vascular only if the bed is vascular.
yeah.
That is as per O.N. Nagy. So the fibular graft, once it is used, if the bed is vascular, that would work well. So if it is a fresh fractured neck femur, it would work well. If it is any bed, whether it is bed is vascular, it would work well. But here it is avascular necrosis. Bed is avascular, so it is very unlikely to become revascularized. So that is the problem.
Okay. So my next question, Debadruti, and the last question of today's seminar is: how far would you stretch your passion of muscle pedicle bone grafting? Stage 4 disease patient, X-ray is asking for arthroplasty. Patient is not ready for arthroplasty. Would you do a muscle pedicle bone grafting in stage 4?
After the first thing is proper counseling. The patient has to understand. I will say yes. Ideally it should be replaced. A total hip replacement is the call of the day. Now, if you are ready, you are not ready for arthroplasty, then we have to offer you something which will give you interim relief. Then we can go for a subarachnoid tenotomy, release the chillas, all the degenerative osteophytes, and do a muscle pedicle grafting, at least increase some range of motion so that it improves your day-to-day activities and activities of daily living. But you should also be ready that in few years time, or maybe we cannot give you the specific time period, you have no other option but you have to go for the final surgery, which is a total hip replacement. So if you are ready for that, I don't want to go for a medical legal problem later.
Of course.
Yeah, just I want to highlight that.
Sure.
So there is a very beautiful question you have asked. So there are several patients we have to see I've been a professor of IPGM here. So almost OPD attendance almost 1,000 per day. So and there are several patients are coming with osteonecrosis very young. within 20 to 30 years, 35 years like that, and they are not ready to do the replacement. So what will do? So actually, I have made a protocol. That is, there are some. That is, age is one. That is, the patient is calling for arthroplasty, but we cannot do. That is a huge burden of patient. That is one. Second, so if the collapse, if the amount of collapse, it is within limited period. That is within 2 to 4 millimeter collapse. So that will lead to limited degeneration, especially in the superior weight bearing area. But other part of the acetabulum is relatively intact. Usually it is studied even in the naked eye during the arthroplasty. So that is the second indication. Third one is, if there is severe restriction of pain, actually I do some traction. Give some local rest traction for at least 2 to 3 weeks till the local inflammation is subsided. Then again, I can examine the patient. If the deflection range of at least, if there is, now initially it was all movements are significantly restricted, like the full-blown picture of the degenerative arthritis. But even after 2 to 3 weeks of traction, once the inflammation subsided, again I have examined, and then there are some cases we have found there are some now the globular restriction is converted to asymmetrical restriction. So especially the internal rotation abduction is grossly restricted, but the flexion is relatively improved. And in those cases, those who have flexion is up to 100 degree, there's more than 90 degree flexion is restored. Then actually I selected those cases for this joint preserving operation. And then I have in my cases at least 50% cases has become significant relief within 10 to 14 days. After that, we can convert it. That means we can buy time before converting those persons to arthroplasty. This is my this experience actually.
Very good.
Another thing is, sir, last point, even as Professor Paul told, post-operative period also in this advanced stage 3 or stage 4, we advocate spat traction for at least 3 weeks. That because that also helps in for the joint distraction. So that also is very helpful for the better result.
Yeah.
And in many of the cases we have seen during the surgery that even in the radiological picture, we don't select cases where there is more than 5 millimeter collapse. So it should be within 4 millimeters collapse of the head. The cartilage is soft, but actually even in the post-op period in our long-term results, there has been improvement, a considerable improvement in the shape of the femoral head and also in the radiological joint space. Even there is a healing of the cystic areas and the fracture lines often disappear. There the gross sclerosis also decreases over time. So these are definitely we have seen when these come for follow-up. But always, as I told you, we should always advocate as an interim procedure, not a final solution.
Of course. Okay. Perfect. Thank you very much. So, Professor Bakshi, any golden words of wisdom from you? What? Because we in COVID are getting a lot of post-COVID, post-steroid avians coming to us, huge numbers, and these numbers are going to go on increasing in our everyday OPDs. So last parting remark by you, sir.
Yeah, when the patient is coming with a pain and evidence of osteonecrosis, you have to do something. What you will do? Give the relief to the patient by decompression, and if there is chillas, you do the chilectomy and try to give them relief. Does not mean that you are saving the head for a long time or whole life, but your object will be to give them relief so that some healing may take place. If not, you may delay the need for total joint replacement.
Yes. Thank you, sir. Thank you very much. You have always been such a blessing giver to at least me and of course orthopedic surgeons all over the country. I really appreciate all three of you joining. Devaduti, thank you very much. Dr. Pal, thank you very much. And Professor Bakshi, Pranam, thank you very much. Please keep your blessings showering always on me and all of us. I want to thank Zuventus and I want to thank Science Integra to put the show together. I'm sure today's knowledge has opened another thought process in terms of salvaging the hip joint, because these are young patients who are coming to us. These patients are patients who cannot spend huge. Hip joint arthroplasty even today has a period of its life, and we cannot have this more. It's always better to have their own hip joint if we can buy some time, as Professor Bakshi has rightly said, even if it is 3 years, 5 years, 10 years, it's worth it having that hip joint, and let patient ask for hip replacement whenever they need. So thank you very much. With this, I close today's topic, and thanks for joining me. Take care, stay safe, and goodbye.
Thank you. Bye.
Thank you.
Thank you, doctors. Thank you for your time.
Thank you. Thank you.
Thank
Bye.
you, thank you.
Bye.
Sir, thank you very much for this. Thanks a lot. Thanks a lot, sir.
Thank you.
Can we leave now?
Yes,
Yeah,
sir,
you
we
may
can.
leave,
We
sir.
can.
No problem.
We
Thank
can.
you so much, sir.
Okay.
Yes.